Hello everyone and welcome to the respiratory system. Starting with a few functions of the respiratory system, probably the first and most important is going to be providing an extensive surface for gas exchange to occur between air and circulating blood. Next is to move air to and from the exchanging surfaces of the lungs along the respiratory passageways, to protect the respiratory surfaces from dehydration, temperature changes, or other environmental variations, as well as defending the respiratory system and other tissues from invasion of pathogens. So if you remember talking about pseudostratified epithelium, we talked about those goblet cells that have mucus inside of them and how you end up coughing up quite a bit of the debris that goes into your trachea. So that is going to be kind of what that's talking about. To produce sound for speaking, singing, and other forms of communication, and facilitating the detection of olfactory stimuli by olfactory receptors in the superior portions of the nasal cavity. So obviously that last one is talking about your sense of smell. Your respiratory system is separated into two parts based on structure, that being the upper and lower respiratory tracts. The upper is going to include the organs in your head, which are your nose, nasal cavity, paranasal sinuses, and the pharynx. Occasionally, the upper respiratory tract also includes the larynx. It just sort of depends on where you're looking. In this instance, go with what I wrote and not what's in the picture. The lower respiratory tract is everything that is from the neck down into the thoracic cavity, including the larynx, the trachea, bronchi, bronchioles, and alveoli. The respiratory system is split up into two zones based on their functions. So that last one was separating by the structures. This is by function. So the conducting zone is going to be where air is conducted into the exchanging area. So that is the nose, nasal cavity, pharynx, larynx, trachea, bronchi, bronchioles, and terminal bronchioles. This is going to be where we filter, warm, and moisten the air and conduct it into the lungs. If you have ever experienced a particularly cold morning or a very cold day and you breathe in really deep and it's this horrible pain in your chest because the air is so cold, it's just because you weren't able to warm that air quickly enough because that air is so cold, and thus you can feel it in your chest. The other zone is the respiratory zone, and this is where gas exchange between air and blood occur. This is going to be located in the respiratory bronchioles, the alveolar ducts, alveolar sacs, and the alveoli. This is a nice picture showing the various structures that we are going to be talking about. I'd make a note of them for later, but I do have a few pictures that you guys can use for these structures. Starting with the upper respiratory tract, we are going to discuss these various anatomical structures. Starting with the initial structure that you probably can visualize pretty easily, that is the mouth and the nose. Now do keep in mind that we have talked about a few of these structures already when it comes to lab. So the nose is going to have two nostrils, or external nares. We do have the nasal cavity, which is going to be separated by the nasal septum and contain the nasal conchae, which, if you need a quick little reminder on what those structures are, we have the external nare going into the nasal cavity, separated by the nasal septum, and then we have these three what kind of look like shelves. Those are the nasal conchae. From there, we have the eustachian tube or auditory tubes, which are going to be right there. They're going to connect the ears and nose. This allows for drainage from the ears to drain into the throat. It allows for equalizing air pressure for the inside and outside of the skull. I also want you to make a note of the sinuses that we can see. These are mucous membrane lined, and they allow for the skull to be lighter in weight. It also helps to humidify the air passing through. When we see the term pharynx, I want you to think throat. The pharynx is separated into three parts. We have the nasopharynx, the oropharynx, and the larynginopharynx. And then we have the larynx, which is going to be a rigid tube of cartilage. And you can see a few of these cartilages here, thyroid and cricoid cartilage. But you can also kind of make a little note that the larynx is the voice box. It is what allows you to speak. It houses your vocal cords. A little bit more about the nose. Again, we've kind of talked about this purpose before, but it is to warm, clean, and humidify the air that you breathe in and out, to detect odor, and it is a resonating chamber. What that means in that it's a resonating chamber is that it allows for your voice to carry a little bit more. It's going to allow for that sound to be able to carry. Your external nose is going to be what you know and love. It is on the outside of your face. It is made of bone and hyaline cartilage. And you can actually see this little difference here, which I think is quite cool, between the cartilage and then the bone back here. So when someone breaks their nose, typically they're probably breaking that cartilage. Less likely they are breaking that bone. We talked about the nares or the nostrils. Those are the two openings. That nasal cavity on the inside, once we go past the nares, the nasal septum is going to divide the nares. If the nasal septum does not align, this is what's known as a deviated septum. What can happen with deviated septums is snoring, as well as other breathing problems, and the only way to really correct it is going to be through surgery. If you look directly into your nose, let's say you are looking into a mirror, you lift up your nose, and then maybe you take your finger and lift your nose further, kind of like giving yourself a pig nose. That is going to be what is known as the nasal vestibule. So keep in mind that this whole thing is the nasal cavity, but this one part right here is the nasal vestibule. This is going to be lined with skin and hair that serves the purpose of filtering out particles. Lately, it's become kind of a fad, I suppose, of videos where people take wax on Q-tips and rip out their nose hairs. First and foremost, I can't imagine how painful that is. Secondly, that's really unhealthy and probably shouldn't be doing it. Around the entrance to your nostril, it's fine to trim those hairs, but to rip them out like that at the root, I would not suggest. You could damage that sensitive skin within the nasal vestibule. On top of, you need those hairs. They are going to stop bugs, parasites, bacteria, viruses, who knows what else. They serve a very important purpose to catch particles and filter them out before you breathe them in. Last but not least on this slide, we do see those nasal conchae. Remember, they are those three shelves, the inferior, middle, and superior conchae. They are also known as turbinates. Their purpose is to increase surface area, prevent dehydration by trapping water droplets during exhalation. They serve a very important purpose. This slide is showing the 4 sinuses that we can see inside of the skull. So you have your frontal sinus, ethmoid, and sphenoid, which are very close, and the maxillary sinus. If you have blocked sinuses, chances are it's just an increase of pressure due to an increase of mucus. If you get sinus headaches, one of the best methods to alleviate some pain is to apply pressure to these sinuses. So squeezing between your eyes, pressing on your forehead, or kind of down on the sides of your nose is incredibly comforting. And if you've never gotten a face massage or given one to maybe a friend or a significant other, they're quite lovely. Moving down from the face, essentially, we're moving into the throat here with the pharynx. Do make a note of this term. It is deglutition. This is the technical anatomical term for swallowing. The pharynx is where we're going to have a passage of food and air, which arguably, if we look at how humans are constructed, this is a very dangerous way to basically have two things that we absolutely must do occurring in the same place. So food is going to go through the pharynx as well as air, which increases the odds of choking exponentially. It's also going to act as a resonating chamber for sound. It will house your tonsils, which are your first line of defense. And then again, it is split into the nasopharynx, oropharynx, and laryngopharynx. So talking a little bit about the respiratory defense system and epithelia. I mentioned before that we have those pseudostratified epithelial cells that are going to line our trachea and kind of line the top of the pharynx. If you remember, they have these little cilia along the edge here. So this is just an open space. This would be like where the food is coming down, or air, or whatever. The cilia is going to be using waves to kind of push up. So if your mouth and everything is up here, and this is, let's say, down to your lungs or whatever down here, it is going to use mucus to trap debris and then move it back up, so you either cough it up or swallow it. And that's kind of essentially what all of this over here on the left is saying, but probably a little bit better than I just explained. Moving on to the lower respiratory tract, you have your vocal cords, which are still technically part of your larynx. This is where you're going to have air passing over the glottis, and vibrate, which is going to produce sound. The trachea is going to be just inferior to the vocal cords. This is going to be what you probably know as your windpipe. It is going to be surrounded by rings of cartilage which hold it open. This is called tracheal cartilage. Moving from there, we have the bronchi, or bronchus, where the trachea splits into each lung. So you have the right and left primary bronchi, where they split, this little fork right here. That is going to be the carina, and I know that's not written on this slide. I believe it's written on maybe another slide, but that is the carina, which is one of my favorite anatomical terms. from the primary bronchi, we are going to split into the right and left lungs, where our bronchi is then going to get smaller and turn into bronchioles. The bronchioles are just smaller, kind of branching structures from our bronchi, where they are going to end in something called alveoli. Alveoli are going to be these little, they kind of look like a cluster of grapes, if you will, but these are little sacs which are just big enough to allow for gas exchange between your red blood cells and the air that you breathe in. And then do remember, and I think we discussed this probably at the very, very beginning of the semester, but the pleural membranes are going to be, or pleural membrane, just one, is what surrounds each lung and connects them to the chest cavity wall. Talking a little bit more about our larynx, we do have something called the vestibular folds. These are known as the false vocal cords. Make sure you make a note of that. When brought together, they function holding in breath against the pressure in the thoracic cavity. For example, when a person strains to lift a heavy object, or quite possibly if you're holding your breath while you're underwater. Your vocal folds are your true vocal cords, and these are going to be the structures in voice production, whether that's singing, humming, speaking, screaming, whatever. Now remember, we do have a few cartilages, but what I want you to know on this particular slide is going to be the thyroid cartilage. This is also known as the laryngeal prominence. On men, this is very prominent. It is what's known commonly as the Adam's apple. Females do have it, it's just not quite as pronounced. Make a note of this next term. It is phonation. Phonation is where you have air passing through the larynx, which vibrates the folds and produces sound. So the production of sound is phonation. When we modify these sounds with our tongue, teeth, and lips in order to form words, maybe changing kind of a B to a T sound, if you can imagine how that feels, how that looks. If you don't believe me, try saying B versus T and feel how your mouth changes in order to get that different sound. That is articulation. So modifying the sounds in order to get these specific sounds, such as B or T. You are using your teeth and your tongue and your lips. And if you are interested, it is kind of interesting to note that a variation in pitch is going to be related to the tension in your vocal folds. Whew, words, guys. Moving on, we're going to talk about the glottis and the epiglottis. The glottis is a lot like the pupil. It's sort of just an opening. The epiglottis is going to be this little shunt that you have, and on this diagram it is this structure right here, which kind of circled that very badly, but it's that blue structure right there. And if you put your finger gently on that part of your throat, kind of directly in the middle, you'll be able to feel kind of a little bump, and you swallow. You're going to feel that little shunt moving backwards and then back in place. And that is because this shunt is going to move to prevent you from allowing food or liquids to go down your trachea. So it is covering your trachea. And if you remember, the term epi just means above, so it's just above the glottis. When it does not completely close off as you are swallowing something, that means that you're going to be choking. So if you've ever been talking or laughing as you've been drinking or eating something, you start to choke, maybe someone had to give you the Heimlich, or, easily just had to pat your back to shake something loose, that is choking. And that is because the shunt did not close off properly, because as you speak, as you swallow, that shunt is moving back and forth, and if you just happen to catch it at the wrong time, well, now you have food or beverage going down the wrong pipe. I like this slide. Do make sure that you know these terms that are kind of above these graphics. So abduction versus adduction, and what the glottis is doing at that time. So when the glottis is open, we have abduction, which is going to be a lower pitch. That also means that our vocal cords are moving further from the midline. And then we have adduction, so the glottis is closing. This is going to produce a higher pitch, and that is going to be where the vocal folds are going to be closer to the midline. Moving on to the trachea and the bronchial branches. So the trachea, or the windpipe, is going to be that tube coming down from the larynx. It does have those ridges. That is a big difference between the trachea and the esophagus, and you'll see when we get to the digestive system how the esophagus looks kind of just like a tube or a noodle. It's very smooth. The trachea is going to have ridges. These ridges are made of cartilage. These are made of tracheal cartilage. They are going to be kind of C-shaped, so they don't completely close in the back, but they are going to be open in the front. Moving on to the lungs. So speaking of sort of the gross anatomy of lungs, there is a difference between the right and left lung. And just so we know, and we make sure that we know, this is the right lung, this is the left lung. So we're always going to go by the model's right and left. The right lung is going to contain 3 lobes, while the left lung contains 2. The right lung has a superior, middle, and inferior lobe, while the left lung has a superior and inferior lobe. Now do make a note of these fissures as well. The right lung is going to have 2 fissures, while the left lung only has 1. They both have an oblique fissure. The right lung is going to contain a horizontal fissure. Now the reason that we have this space is because in the left lung, space, why we have this difference between our right and left lung is due to the cardiac notch. The cardiac notch is going to be where we have the heart. The heart is going to be placed right here, and that is why the left lung does not have a middle lobe. Do make note that the base of the lung is going to be this inferior flat portion, while the apex is a pointed portion, and that you are going to have 2 pleural cavities. So these are cavities within the thoracic cavity, so within your chest. You have 2 empty spaces perfectly laid out for both of your lungs. The hilum, or the hilus, is going to be where we have blood and lymphatic vessels coming in and out of our lungs. So I kind of like to think of this as almost like a trunk. The lungs have a tendency to look kind of like a tree, and you'll see what I mean here in just a moment. But the hilum is almost like a trunk that is not only sort of holding the structure in place, but there's a lot of nutrients as well as waste coming through and going out through that area. Moving on to our bronchi. So we have talked about the larynx, we've talked about the trachea, and we're moving down to our lungs, into our lungs. So as I said, this is the carina where the bronchi split. We have one going into our right lung and one bronchi going into our left lung. What's interesting about the right bronchus is that it is more vertical and shorter and wider than the left. This means that aspirated objects, so things that you might choke on, are more likely to enter and lodge in the right bronchus than they are the left. I had a nephew who choked on a peanut, and it went straight down his trachea and into his right lung. It did need to get surgically removed, but it was terrifying for a second, but it did exactly what the doctors predicted, and it went down into his right lung due to the structure being slightly different than the left. From your primary bronchus, which is this green structure that we can see right here, we do have the secondary bronchi and then the tertiary bronchi. Now, there's not all that much of a difference between these structures, aside from the fact that they are just like limbs of a tree getting smaller and smaller as you make your way out to the edges of the tree itself. So as I said, I picture the lungs quite a bit like a tree. You've got this primary trunk going into these kind of larger limbs, if you will. We do have a forking as well. And then the limbs are just going to be getting smaller and smaller and keep branching off until we get to the bronchioles and the alveoli, which I think of the bronchioles as being like very tiny, like little twigs and sticks, while the alveoli are much like leaves. They're at the very ends of those tiny sticks, those bronchioles. Bronchioles are going to lack cartilage. They have a relatively thick layer of smooth muscle. There is a difference in how they constrict and dilate, and this is actually going to come into play when we talk about asthma. We have bronchiodilation and bronchioconstriction. Dilation is going to mean that it's going to be a relaxation of that smooth muscle that makes up the bronchioles, which is going to increase the diameter and airflow coming to and from the lungs. Bronchioconstriction is going to be a contraction of that smooth muscle, which is going to cause a decreased diameter and decrease our airflow. So this is where you may have an asthma attack. An asthma attack is going to be extreme bronchioconstriction, which may be in response to an allergic reaction. Typically that's sort of the example I'm thinking of. I'm sure there's more, but you can think of an allergic reaction. So from the bronchioles, we are going to enter into the alveolar sacs. These are going to consist of 2 or more alveoli and share a common opening. So like this guy right up here. So this is an alveolar sac made of plenty more than 2 alveoli. And if you remember me saying this before, they kind of look like a cluster of grapes. But do keep in mind that these little grapes individually, they are hollow. There's nothing inside of them. So getting a little bit closer, we can see a few things that might look a little bit familiar from one of our very first lectures, and that is what all these structures actually look like if they've been dyed with this nice purple dye and sliced very, very thin. So here we have our tracheal cartilage, which this should look very, very familiar when we think about what cartilages look like. We have a bronchiole right here, so that's just a little tube. We can see the smooth muscle surrounding it. And then over here, I think this one's really, really interesting. We can see our alveoli and alveolar ducts and how they are hollow. So let's talk about pulmonary lobules and the respiratory membrane. So we do have our alveoli, which are going to be supplied by an alveolar duct. And if you look over here at this graphic, we have our alveolar duct right there. They are going to be attached to a common chamber, the alveolar sac. So this whole thing here. And surrounding these alveolar sacs are going to be an extensive network of capillaries. And remember, capillaries are going to be those smallest blood vessels that you can get. So what's happening in these capillary surrounded alveolar sacs is going to be gas exchange. So the red blood cells that are going through these capillaries are dropping off their carbon dioxide, which is then going to be diffusing through membranes in order to be emptied into the alveoli. And the alveoli are then transferring oxygen to those red blood cells. Remember, capillaries are only big enough for about one red blood cell to go through. Now, another thing that's kind of interesting to note, because we've talked about it before when we talked about the lymphatic system, you'll notice that when I mentioned the hilum earlier, which I kind of think of like a trunk or a really thick limb going into the lungs, it included blood vessels and lymphatic vessels. Now, the lymphatic vessels are very important because remember, anytime you have these capillary beds and we have this exchange going on, there's also going to be lymph that is going to stay within the tissues. The lymphatic vessels that are going to be within our lungs are incredibly important. And if they were not functioning properly, you could potentially drown in your own lymphatic fluids. So they are going to carry away all the fluids that our blood is essentially dropping off as it is going through gas exchange. So little callback to when we were talking about the lymphatic system. All right, so a lot of what I just mentioned you can kind of visualize here in these two graphics. So we have all these capillaries over here on the left surrounding our alveolar sacs, and we have gas exchange going on the inside. So we have the outside on the left and the inside of an alveoli on the right. So we have venous blood, so blood from veins, which are typically going to be low oxygen. Coming in, they are dropping off our CO2, we are picking up oxygen, and we are leaving with high oxygenated blood. It's as simple as that. There are 3 types of respiration that I would like for you to know. The first is going to be known as ventilation, which is just breathing. It is physically moving air into and out of your lungs. You're probably doing it right now. There is external respiration, which is the exchange of gases between the alveoli of the lungs and the blood in the pulmonary capillaries. So this is where your capillary blood is going to gain oxygen and lose CO2. So this is what physically is happening within your lungs. And then internal respiration, which is going to be different than external respiration, where you have the exchange of oxygen and carbon dioxide between the circulatory system fluids and respiring body tissues. This can also be known as cellular respiration. So this is going to occur pretty much everywhere else in your body aside from in your lungs. So this can include muscles, this can include epithelial tissue, this can include literally everything other than the exchange of gases within your lungs. Moving on to the oxygen transport in your blood. So 98.5% of oxygen is bound to the iron ions in the heme units of hemoglobin, which, if you need a little refresher, take a look at this little picture down here. We have our four protein subunits that are going to contain a heme. So those proteins are going to be our globin, and within them we have our heme. The heme is going to have an iron molecule in the center, which, if you remember, can contain 2 oxygen molecules. So remember, for each iron molecule, you can have 2 oxygen attached. And that's pretty much what this whole slide is sort of talking about. So now that we know some of the anatomy and a little physiology, there's a lot of things that can honestly go wrong when it comes to the respiratory system. So let's talk about that. So a few terms for various damages to the respiratory system include sinusitis, which is an inflammation of the sinuses, so that mucous membrane becomes inflamed. We have otitis media, which is when fluid can't escape the eustachian tube, and bacteria is going to grow in that area. This is known commonly as a middle ear infection. So if you've ever had an ear infection, that's what this is. Laryngitis, which is an irritation of the vocal cords. It can result in a low, husky voice. I always think of Phoebe from the show Friends when she gets sick and she has that sexy low voice. Tonsillitis, which is an inflammation of the tonsils. This is kind of a very important infection to make note of, because due to this inflammation, if it continues to happen, you may have to get your various tonsils that are more prone to infection removed, which, remember, it's important to have those tonsils there, but if they're causing problems, obviously you should get them removed. Bronchitis, which of course nobody has time for, is an inflammation of the bronchial tubes due to increased mucus or damaged cilia. Pneumonia is going to be a bronchial infection that gets into your lung tissue. So if you've ever heard of pneumonia or double pneumonia, it is just talking about, did it go into one lung or did it go into both? This is going to result in fluid filling up your alveoli, and obviously you're not going to have very good gas exchange occurring if those alveoli are not hollow and able to contain air and carbon dioxide for those exchanges to occur. And then last we have asthma. Asthma is going to be an intense immune response, which is going to constrict the bronchial walls, as we talked about before when we were talking about the bronchioles, and also produce mucus, overly produce that mucus. So asthma is kind of a pretty big deal. Quite a lot of people have asthma, and maybe we don't always know how asthma is treated. We see these little inhalers, but we don't quite understand maybe what they are, what they do. So how you treat asthma is through medication by using an inhaler. When someone has an asthma attack, that means that their bronchioles are constricting. So remember, those very, very small structures, the kind of twigs before you get to the leaves, which is the alveoli, are decreasing in diameter, which is going to not allow for airflow to be going in and out. The walls will become inflamed, as well as due to there being too much mucus. One of the medications that you can take is albuterol. This is a bronchodilator, which is going to increase the diameter of those bronchioles. So it's going to allow for almost instant increase in airflow. So when it comes to the respiratory system, sometimes things can happen where an individual goes through an experience, maybe something traumatic, where they stop breathing. Now, That act in and of itself, of course, is very traumatic, very bad, but the thing that can result from not breathing, and specifically not getting oxygen into the bloodstream, is going to be brain damage. So this is called cerebral hypoxia. This is oxygen deprivation to the brain. Within 5 minutes of no oxygen getting to the brain, brain cells will begin to die. And if you remember, we talked about how neurons, they can heal themselves, but not very fast and not very often. So typically, once brain cells or neurons start to die, they're kind of dead forever. There's no really coming back from that, which can leave someone unable to function properly, maybe cause other health issues, or maybe they never regain true consciousness. We did talk about CPR, cardiopulmonary resuscitation, and how it keeps air flowing into the lungs, which is essentially like forced breathing. CPR is going to encourage the flow of blood and thus oxygen to be moving to the brain. So that's very, very important. If someone stops breathing and you are trained in CPR, it is a life-saving technique. If you are not trained in CPR, I would never suggest doing it. You can be sued if you do not have training and are certified. If you are certified, I've heard that you cannot be sued if you try saving someone's life who needs CPR. If you are not trained, do not try it. You are more likely to hurt that person more than you are to save them. This slide always kind of makes me giggle. Speaking of brain damage, not that he has brain damage, but if you've ever heard of what I consider the not magic magician, David Blaine, who's really quite interesting as a person and as an illusionist, which he's not really doing an illusion, he is pushing his body to the absolute limits. He's really quite interesting. He goes through rigorous training and daily exercises or meditation in order to train his body to use less oxygen and slow his heart rate. What's interesting is he's tried to put himself into situations where he breaks records by holding his breath underwater. He actually got his inspiration from the child that fell through the ice a few years back in St. Louis and was under the water for, I think it was around 15 minutes, and survived. And the kid came out of, I believe, a coma, and essentially he was pretty all right. So David Blaine thought, well, I could be underwater in ice cold water, just recreate what that kid kind of experienced, and he absolutely could not be conscious and stay under freezing cold water. So he had to look for different ways to do this, and I believe he tried blood doping as well as just training his body to not need as much oxygen in order to hold his breath for longer. And I think he was somewhere around like 16 or 17 minutes. I could be wrong, but he's really quite interesting as a person. He really pushes his body, and if you get anything from this class, watching him, you just really wonder kind of that ability to do that. So go check him out if you want to. And I don't want to get on a soapbox, but I'm gonna, because it's important for you to know this information, at least in my viewing of the respiratory system. I think it's very important to make note of how tobacco affects the respiratory tract. So the first term I want you to know is carcinogens. Carcinogens are cancer-causing agents. This means that they are going to change the structure or sequence of DNA, which is going to cause mutations, which, you know, if you think about mutations, say as like X-Men, or, you know, something that causes something really cool like evolution, that's great. But these are not good changes. These changes are going to cause cancer. These changes are not good. carbon monoxide is going to be a byproduct of burning cigarettes, and particulates are going to be what you see when you burn a cigarette. That is the smoke that is coming off of the cigarette as well as what you are breathing out. What this actually is partially burned tobacco, paper, and whatever else is included in the cigarette, which, if you think of it as not being a gas and being solid particulates, being solid, small things, that should hopefully get you to stop smoking, or at least consider the fact that you are breathing out solid material. To the right is going to be some of the contents of cigarettes: arsenic, acetic acid, paint, methane, ammonia, cadmium, which is found in batteries, butane, formaldehyde, which is exactly what you think it is. It is a chemical used for preserving bodies, hexamine, carbon monoxide, methyl, toluene. It's a lot of things that honestly shouldn't be in something that you are ingesting into your body, which I think the last time I looked it up, most cigarettes contain somewhere around 5,000 added items, which is kind of crazy, but it's what makes them so fun to smoke, I suppose. That was the only explanation I could get as to why you would need to include so many extra things. So smoking versus breathing, if you've never smoked before and maybe you're considering it, do keep this in mind, that when taking a drag from a cigarette or from a joint or anything like that, anything that you might be smoking, your brain is controlling the action. This is not a subconscious action. This is not something you're not controlling, such as breathing when you're sleeping or breathing when you're not thinking about it. As you take a drag, you are thinking about it, and you are going to inhale deeper than you normally would and hold it in for longer. What this causes is deeper breathing, obviously, but you're breathing in those particulates even deeper than you normally would. You're holding it in for longer, so it's staying in your lungs longer than a normal breath would. And what this can cause is damage to your alveoli and inflammation to the lungs. What this will end up causing is scarring and reduced elasticity in the alveoli themselves. What this can look like is those individual alveoli end up having the walls breaking down. They become more frail. They don't hold oxygen, and air ends up staying within that cavity and unable to kind of escape. Along with, if you've seen smokers' lungs, which was on that last slide, they look substantially darker, not that healthy pink that you should see with lungs. This darker color is due to those particulates attaching to the alveoli themselves and causing less surface area because they're basically just dirty, if you will. Emphysema is going to be something that can be caused when the air sacs or the alveolar sacs are damaged and become enlarged. So like I said, those walls break down and you don't have individual alveoli within the alveolar sac. You just have this gigantic balloon, if you will, but it's completely hollow. There's nothing inside of it, I mean, aside from particulates, but that's not going to allow for good gas exchange. Again, this is going to be where old air becomes trapped. You can get chronic bronchitis, and the lining becomes covered with the deposits of soot, carbon, and particulates. Not a good thing. Now comes the question, is alternatives to smoking cigarettes better? And the answer is a little bit mixed. They are better, quote unquote, but they are not completely without their potential problems. What vaping or e-cigarettes or anything that is sort of that electronic passing of water vapor is going to contain a higher concentration of whatever it is you are breathing in, whether it's nicotine or marijuana or various oils or things like that. It's going to contain a higher concentration of those things, which means that if it's nicotine, which is a highly addictive substance, you are going to be more addicted to that than, say, potentially to a cigarette, which is not going to have as much of a concentration of nicotine in it. One of the things to really look out for if you are vaping, and if you do have any juice near you, I would maybe double check some of the things like the flavorings. Flavorings like diacetyl is going to give the juice a buttery type flavor. What it can cause is damage to your alveoli by making them more narrow. This is called popcorn lung, and where it gets its name is that diacetyl is a flavoring used on theater popcorn, so movie theater popcorn. And as delicious as it is, if you breathe it in its more powdery, kind of floating through the air phase, then it can cause these holes in your lungs, essentially, which is what this little bottom right picture is showing, which is not a good thing. One of the other things that happens when you have essentially a little electronic device that you're smoking from is that they have been known to commonly explode. And while it may not happen to you, God forbid, it can happen. This gentleman here experienced his pen exploding in his mouth, which, as you can see, he has lost teeth. He is burned on his face and his lips, and I'm sure he probably has damage to his tongue as well. But in the end, yes, anything electronic, such as pens or e-cigarettes or Juuls, are technically 80% less dangerous than smoking a cigarette. You're not technically burning anything, it's just nicotine vapor and probably some added chemicals that probably aren't good for you to breathe in, to be perfectly honest. But again, it's better than cigarettes, but what's better than all of that is just not doing it at all. And this is why. Lung cancer. So lung cancer causes more deaths per year than any other type of cancer. It kills more people per year than colon, breast, and prostate cancer combined. Over 50% of lung cancer patients die within a single year of their diagnosis. So this is, and I know on my soapbox it sounds really dramatic, but that's because it is. And I care about your health. I want you to care about your health too. So this is a very heavy thing to talk about, I know, but just keep it in your mind as you make choices throughout your life. We have already talked about one of the diseases that I would like to discuss for diseases of the respiratory system, and that is tuberculosis. So very briefly, just tuberculosis, remember, is a bacteria that can spread from coughing or sneezing. It creates those crevices which then fill with fluid and you end up coughing that up. But the one that we have not yet talked about is cystic fibrosis, or CF. This causes an overactive mucus production, so those goblet cells go into overdrive. And this mucus is not normal per se, it is very thick and very sticky. It is going to increase that individual's coughing, wheezing, and chance for infection, because with that mucus, it's not leaving your lungs, or your bronchi or your trachea. It is sitting there and it can collect bacteria, it can collect viruses, it can collect pathogens. It's not good, and that is a pretty sweet place for those various microorganisms to go live, which can cause infections, of course. Lung transplants are sometimes necessary. It is one of those things where, despite having a transplant, you still have that disease. It is a genetic disease. It is not something that can be cured. Once you have it, you have it. You are born with it. So despite having a transplant, it only adds a few years to that person's life. It is not a cure. It is a temporary addition of years to that person's life. Next up, we're going to talk about something called COPD. This is chronic obstructive pulmonary disease. When someone says they have COPD, it's not just COPD. Typically, they're going to have one of the following, which can be asthma, chronic bronchitis, or emphysema. So if you ever heard that term COPD, ask them what it is, what specifically they might have. But this is going to be some type of progressive disorder of the airways that is going to restrict airflow. And we've talked about all of these. And then last but not least, I do want you to know these terms, hypoxia versus anoxia. Hypoxia means that it is low tissue oxygen levels. Anoxia is no oxygen supply. Just know the difference between the two, and I hope you enjoyed this lecture.